Hi, my name is Vikas Shah, and in this video I'm going to be talking about the anatomy of the anal canal. This is an illustration of the coronal anatomy of the rectum and anal canal, and I'd like to thank my Radiopedia colleague Andrew Murphy for this illustration. So what we see here is that the anal canal is a continuation of the rectum to become the very terminal part of the digestive tract. The longitudinal muscle layer of the rectum continues to become the internal sphincter of the anal canal, and remember that this is smooth muscle. Now lateral to that we have the skeletal muscle known as the levator ani muscle, and these fibers continue to become the external sphincter of the anal canal, and specifically the puborectalis, which forms a sling around the back of the anal canal. Between these two sphincters we have this sliver of fat which is known as the intersphincteric fat, and this becomes important when we look at fistulas. Here we have something known as the dentate line, which you don't really see readily on imaging, but this is an important landmark because the arterial supply and venous drainage is different above and below the dentate line, and also the nodal drainage. So specifically thinking about the nodal drainage and why that's important for staging of cancers, above the dentate line the drainage is to the internal iliac nodal system, and below the dentate line it's to the superficial inguinal node. So this is why when you see anal squamous cell cancers, you'll often see involved lymph nodes in the superficial inguinal region. Another bit of important anatomy here is this fat, which is the ischioanal or ischiorectal fossa fat, and when you're looking at fistula tracts you'll see them draining into this area, and sometimes there'll be associated abscesses as well. So let's look at some anatomy on an actual MRI. So on this sagittal image we can see here that the sphincter muscles, this is the external sphincter here, and then in between the two we have the anal canal. It's sometimes difficult to see on a sagittal image the details of the sphincters. Higher up we see the rectum. If we go to the coronal views, then what we see is here we have the puborectalis forming a sling around the anal canal and lower part of the rectum, and as we scroll more inferiorly you can see that very thin sliver of fat lying there between the internal external sphincters, and then here this is the ischioanal fossa fat lying outside of the sphincters. And finally on a coronal view you can again see all of that. So here we have the levator muscle forming the external sphincter, the muscle of the rectum continuing as the internal sphincter, which is over here, and then between the two here we have the intersphincteric fat. So for the rest of this talk I'm going to focus on the anatomy of fistulas, and originally Park's classification was used to classify fistulas, and there were four main types. So an intersphincteric fistula is the most simple type, so the infection would begin in one of the anal glands near the dentate line, and then penetrate through the internal sphincter, drain down the intersphincteric space, and then down to an opening at the anal margin on the skin. A transphenteric fistula tract, instead of heading down the intersphincteric space, will traverse the internal and external sphincters and then head down the ischioanal fossa to an opening at the skin. And then the least common are the suprasphincteric and extrasphincteric tracts, which you can see on this side, where for a suprasphincteric tract the tract crosses the internal sphincter, ascends in the intersphincteric space, and then heads back down after crossing through the levator muscle. And an extrasphincteric tract, really the internal opening is a lot higher up, and then it drains again through the levator muscle and down to the skin opening. Now there was a modification of this called the St. James's University Hospital classification, which reflects a bit more realistically the different kinds of tracts and anatomy of tracts that we see in clinical practice. So let's go through those. So the first one is just like the Parkes classification, a simple intersphincteric tract, this one here in purple. So here on this axial image what you can see is that there is a tract here extending from the posterior wall of the anal canal from the 6 o'clock position and down to the skin opening in the intersphincteric plane. There are no associated secondary branches or collections. So this is a simple intersphincteric fistula. This is a grade 1. So 2 is an intersphincteric tract with an associated abscess or a secondary tract. So you can see that over here, intersphincteric tract, and then there's a little secondary branch heading superiorly, and here a small focal collection as well. So let's look at an example of that. So here we have a intersphincteric tract which is beginning here on the 2 o'clock position, 1 to 2 o'clock position, extending down the intersphincteric space here, and then in the ischoanal fossa near the skin opening you can see there's this focal expansion. This is a small localized abscess just proximal to its cutaneous opening, so that would be a grade 2. A 3 is a transphenteric fistula tract with no complications such as secondary branches or abscesses. So here this is a volume acquisition of the anal canal. In fact, my clinical practice, the way we do anal fistula studies is to acquire a volume, and then that can be reconstructed into different planes. So if we start here, we have the internal opening right laterally on the anal canal, and then as we come down we see that there is extension into the intersphincteric space. So there's a horseshoe shaped intersphincteric collection. We continue going down. On the left side then, this extends out through the external sphincter complex and then down to the anal margin, running down the ischoanal fossa. Okay, so it comes out, runs in the intersphincteric space, passes through the sphincter complex, and then down the ischoanal fossa. So that's a simple transphenteric fistula tract, even though it's not coming quite directly out and it's got this intersphincteric component. It's not really an abscess, and that's not really considered to be a secondary branch. Then we have the transphenteric fistula, this one here, but with an associated abscess or possibly a secondary tract in the ischiorectal ischoanal fossa. So this is an example. We've got an internal opening here and then this posterior collection here. The tract comes out through the sphincter complex into the medial left ischoanal fossa. There's this anterior component here, and then the tract for the most part descends down here. It's quite wide bore tract down to an external opening. And if we look at the coronal images, you'll appreciate there's that the tract comes out, but there is a little extra component here, a little branch that would constitute this as being a 4 rather than a 3. And then finally 5 is either when there's supralevator extension or translevator extension of a fistula tract. So this coronal study, the coronal image here shows a tract which extends from the skin all the way up the ischoanal fossa and then just diving into the lowest portion of the levator muscle just above the top of the external sphincter to an internal opening. So that would just about be graded as a grade 5. So that's the St. James's University Hospital classification of anal fistulas. Thank you very much.